Thanks, everybody. It makes an awful lot of sense for health insurers to get involved in prevention, you'd think. On the one hand, it's a win-win, isn't it? On the one hand, you get members who are going to get healthier. On the other hand, health insurers are actually going to save money in terms of claims. Well, I wish it were that simple. HCF's made a very concerted effort over a long period of time, putting a lot of money behind prevention, and it is a tough gig. One of the very first questions that we had to grasp or get our head around was how we were going to engage in prevention. One of the conundrums is that health insurance isn't really health insurance. It's actually hospital insurance. So what that means is that we just cover the hospital event. All of those health events that occur outside of the hospital gates, the GP and the PBS medicines and specialist consultations, are not part of what we cover in our health cover. What does that mean? That means that our language of understanding the healthcare environment is actually based around bed day utilisation. And that puts a completely different framework when you start looking at how these things work. And that means that it really wasn't sensible for us to get involved in primary prevention. We maybe promote healthy activities and things in our magazine, but it's not really where the main game is. Arguably, lots of diseases take a long time. Chronic disease over many years before they get to the stage where you might need to go to hospitalisation. If we were going to make any difference, we'd have to make a difference at the level of that hospitalisation. So our focus had to be on secondary or tertiary prevention around those people who've got chronic diseases and how do we prevent them going on to get complications of those chronic diseases. So what did we do? This is basically the list of the initiatives that we put in place. And our flagship program is called My Health Guardian. We started this in May 2009. Within 1 year, we'd had enrolled 25,000 people on this program. To date, we have 27,500 people on the program. What is it? It's a chronic disease management support program, which is operated over the telephone by nurses, registered nurses, who are trained in health education, behaviour change, wellness, and trying to get people educated about their disease, about the complications of the disease, their risk factors, and trying to motivate them to get engaged, and works with a general practitioner and the general practitioner's care plans. And it's also supported by web and mobile applications. But wait, there's more. We also have a number of people who are getting telephonic support. They don't just get a set of knives, they also get this, which is a 4G hub that transmits information from glucometers, which are wireless glucometers, and blood pressure machines. And it actually sends this information through to the Healthways nurses. We've got 1,500 people which are using that at the moment, to be up to about 3,000 people in the next 12 months, which is the largest telemonitoring initiative in the country, actually. So with all of this, the aim is to get people healthier and more engaged and change their health-seeking behaviours. We have a small program called My Helping Hand, a completely different scale program, 33 people at any one time. It's a short-term program around people with mental health conditions, trying to understand the triggers of their mental health condition to try and avoid them going back and being readmitted into a mental hospital. Then we also have a number of programs, which I'll describe in a bit more detail later, around weight management. And again, these aren't just simple weight management, they're in a particular condition. So weight management in osteoarthritis, weight management in cardiovascular disease, or weight management in diabetes. Because when we started looking at weight management alone, the ROI just didn't stack up for us. When we started applying these sorts of things based around people who've got chronic diseases and are more likely to be going into hospital more frequently, it starts to show a very different type of ROI. So I just thought I'd put this picture in to show you that there are some part of our website. This is part of the engagement on our chronic disease management website. There's also a mobile application that goes with this. But I put this in as a reminder to sort of talk to you about engagement, because it's been a really battle for us to get 27,500 people on these programs. We use every piece of data we possibly can to go and invite people onto programs by letter or by telephone. But as a health insurer, we don't have a lot of data to work with. We don't know who are our smokers. We don't know what people's weight are. We don't know a large know who's diabetic, who's not, who's got COPD, who hasn't. Once they've been to hospital, we know more about them because we collect information from hospital, and we can use that to proactively reach out to people, and that's how we've done a lot of the engagement. We've tried using the web as an engagement tool, but it's tricky, and I think people don't see or find it difficult to engage on a health ticket through the web. We need other strategies that will help us engage with people. I wanted to talk to you about the success of our programs. So this is the My Health Guardian program with our current active enrolments, and this is again bed days per 100,000 on this side. So getting back to what is our overall metric. This is what was the pattern of these people prior to joining the program. The program went live in May 2009, and that's the bed day utilisation since. And you can see there's been a levelling out. Now this is not a statistically significant, and you can argue. I'm showing you raw data, but at least you can see what it looks like, and that's real data. This, by the way, at the bottom is the rest of HCF, which you can see we were certainly getting selecting the people who were sicker on an upward trajectory, and that trajectory has certainly levelled off. We've done more rigorous research, and this is actually was published last week. And this looks at a matched cohort. So taking, getting a control group is extremely difficult when you're running a program. This is not a randomized controlled trial. This is an ongoing program. We're trying to offer it to as many people as possible. So what we've used is a way of doing a matched comparison, getting a matched comparison group. It's called Coarsened Exact Matching. And if there's any statisticians around, you can talk to me afterwards and tell me what that is. It's complicated, but what this is already showing is a number of reductions in hospital admissions, readmissions, and reduced number of bed days in a selected subset. So in this case, this is people who've got diabetes and have got cardiovascular disease, but we've not really seen achievable statistical significance in some of the other conditions as well. So in some areas, these sorts of programs can be really effective. In other areas, it's harder to measure. We also have problems with around how do we actually, once we've delivered a program, the costs of the program detract quite significantly from the results. It's actually a lot of infrastructure and a lot of work behind putting a nursing system in place via telephone. And then we have a unique thing to health insurance called risk equalisation. So basically 46% of any savings that we get in our health funds due to helping people out goes to our competitors. And that is just a simple mathematical thing about the way health insurance works, the way community rating works. And it just works against any fund that's proactive in trying to make our members healthier.
Unless the other funds are as well.
Unless the other funds are doing so well. And if you get a disproportion, we're cross-subsidising those that aren't doing it well. And arguably, that's one of the reasons we've tried to promote this with some of our competitors, and why we actually work with our competitors on these sorts of things. I'll show you an example in a moment. So, weight management's a really big area for us. Doesn't work on its own, but on just when someone's overweight. But if they have got underlying disease, then they would be a candidate for our weight management program. It's an 18-week program. It combines very low-calorie meal replacement, sizing of meals. It's supported by internet. You have to go in and log in and put your progress in on the internet to continue to get the support. And if you don't go in and log in and register, you get a telephone call and somebody reminds you and chugs you along and kind of keeps your enthusiasm going. And we get high retention rates on this. Once we started chasing people up, we get retention rates in excess of 80% on this program. We've seen on average 7.5% reduction in weight on this program, and you can see here the weight loss in various weight loss categories is quite reasonable. There's a few here probably less engaged than most. 7% of them had a weight loss of less than 2.5%, but with 30% of the people getting greater than 10% weight loss is pretty good. Now, what we also measure with this are other measures of disability or ability, KUS scores, which are about people's knee symptoms, pain, flexibility, movement, and those sorts of things. And the SF-12 score, which looks at general physical functioning, mental functioning. And we're seeing positive movement on all of those scales, and we're seeing an effect which is dose-related, so that the more weight loss you lose, the better your physical functioning, the better your mental scores are, and your physical scores are. This is just about to be presented at the Seattle World Congress on Osteoarthritis later this month. The kit itself, I'll show you if you want to come to the front at some stage. It gets delivered to people. They get packages like this, which are the Kickstart the LCD, things to size your meal, shakers, and there's actually a lot of materials, a lot of educational materials, all phased in a sort of programmatic form. If you're on the osteoarthritis program, you get physiotherapy on DVD and other things to assist you building up strength around your knee joints, because that makes you a better surgical risk, and it also reduces your weight and your needs to go to surgery. So, and this is an example, getting back to your point about collaboration across health funds. So this program actually, although HSF was one of the main protagonists of this program, we've actually got other large health insurers on board with that. At least another 3 of the largest health insurers are actually supporting this initiative as well. So there's a lot of stuff going on in the space. It's not an easy space to do the measuring and monitoring, but I just wanted to share with you a flavour of what we're doing, because in 15 minutes it's pretty hard to kind of condense 10 years of work. But anyway.